could I be joined now by Dr. Robert Arnold, Mary Matthiesen, Peter King and Sue Pieters-Hawke. If you could come and take any chair that you wish and excuse the mess that's sitting on the front of the stage. Would you clap them as they come, the clap of encouragement? And Robert, if I could ask you just to take the microphone that's there, and I asked Robert for an example of some form of community action from his corner of the universe, and he mentioned, I was hoping, Robert, you might take the microphone, if that's okay, and explain what Compassion Sabbath is. It's on. Yeah.
Can I get more than 140 characters?
Yeah.
It's something that happened in Kansas City and then has happened in other cities in the United States, where on Sunday morning the ministers at all the congregations, and on Friday evening, sort of on a weekend, all the ministers and rabbis and pastors talked about end-of-life care and advanced care planning, and so they sort of spent a very concentrated amount of time and tried to get people to sort of think about and fill out advanced care directives.
So don't you think a fantastic example of reaching a very large proportion of the population? The purpose of this panel is to share priorities for action, to really make a difference, to reach outside of our own community, to promote the great benefits of palliative care to the broader community. I guess partly so the community can be advocates for the change that this whole conference has been about reinforcing. The mic's on, you don't have to worry, Peter. Let me introduce Peter King, who's a former carer for his wife Carolyn, who died when she was 38, and his mother Beryl, and he supported both his wife and mum at home. Peter's an economist and a builder, a building contractor and a father of three, and also a social researcher. Would you please make him welcome? And I'll also welcome Mary Matthiesen, who's the Director of Conversations for Life in the United Kingdom. Please make Mary welcome. And we do have people who weren't here yesterday, so they won't have heard Sue Pieters-Hawke speak yesterday, but Sue's the National Ambassador for Alzheimer's Australia, the co-chair of the Federal Minister's Dementia Advisory Group, and of course the author of Hazel's Journey and also Hazel, My Mother's Story. So please make Sue welcome again. And I want to start with Peter because he's got a fascinating question that I'd like the panel to answer as well as members of the audience. But before we get to your question, Peter, can you just tell us, in essence, the experience you had of caring at home for your wife and then later your mother, and what were the key elements that made that such a positive experience for you?
Yeah, thanks, Julie. My wife got breast cancer in 1993. It took 3 years to kill her. It was a very aggressive form of breast cancer, and we all went to hell and back during that period.
Just pop it closer to your mouth.
Sorry. So breast cancer, we were 30, she was 34, and I was 37. We were we're a young family at the peak of our game. Our youngest daughter was 1, our middle daughter was 6, and our eldest daughter was 7. So she got the terminal prognosis in 1996 or 1995, the end of it, and we had about 5.5 months where I nursed her and fulfilled her wish, which was to die at home. I was under contract, as it were, because she made me, I promised. And because of her experience, I think it's really important to understand the meaning of this experience, this palliative care experience, by referencing where we came from, how we came to be in this situation where Caroline's life was to be taken away and our lives were shattered, something that we had never ever considered. And the key is that she suffered. She suffered terribly in the hospital system. They threw everything they could at it. It came back, it metastasised in her bones, and she ended up having enormous pain. Almost, you could say that it was uncontrolled or uncontrollable during the palliative care period. This was a life-changing experience for me. I discovered that there is this thing called palliative care, home-based palliative care, and that there are palliative care specialist nurses and doctors who do just an amazing job. They gave to me, it's a cliche, but please don't ever think that your work goes unrecognised by the people who know what you do. They empowered me to give my wife Caroline a good death. I gave her a good death, and in the process I grew. I was rewarded infinitely by the work that I did, which I couldn't do for a single day without the support, the understanding, the trust, the commitment of these palliative care nurses and the palliative care system. We're from Adelaide. And then 9 years after, that's 18 years ago, my kids are all grown up now. 9 years ago, my mother got bowel cancer with a terminal prognosis, and she asked to move in and for me to do it again, and I did it again. I would do it at the drop of a hat again and again and again. And I want people to know that this exists. It's possible to do it. You don't need any kind of specialised knowledge. That there is this outreach support mechanism which will train you, guide you, trust you, look after you, and do it, again, a cliche word, but holistically. Do it with the family, for the family. That was a life. That's the background to me.
And Peter, who we've met before because I was the MC of the launch of Palliative Care Week at Parliament House in Canberra, and I interviewed Peter as part of that, relatively recently. So I have heard your story before, and I know that Peter is passionate about becoming an advocate for home-based care. And I might say he did some passionate advocacy to the Health Minister and the Social Services Minister and a number of senior advisors who were in Parliament House, Canberra, hearing at greater length the story that we've just heard more briefly. So his question is, how can I become an effective advocate to enable as many people as possible who wish to die at home, to have the services that enable them to die at home? And I thought, before I ask for some answers to that question, give us a sense of what you're thinking already, you're doing now and you'd like to do in the future.
Okay, so I've spent the last 18 years just trying to make a living and bring up my 3 girls. They're now grown up. I don't need as much money. I can let go of some of the work that I do, and this is my thing. It's always been my thing since this first happened, and I want to advocate for people to know, understand and call for this in the home. I'm very strong on this in the home business. And so I put my hand up with our local, the SA equivalent of Palliative Care Victoria, and said this was just 6 months ago, I said that I was able to be available to advocate, to speak to groups, to write, to do whatever. And so I intend, and so this is the second speaking engagement that I've had, and I feel very privileged to have been invited by Odette to do this and to put me up in the hotel and to meet you wonderful people. You just are amazing. You don't, I think, realise what a difference you make.
And you're interested in establishing a website?
Yeah, so I want to establish a website that just ordinary people can click on and be encouraged to do what we did, as well as make myself available to speak.
First of all, can you give him a round of applause for his opening remarks? And could I ask the microphone to be passed up to Mary, please? Thank you. And just reminding you that Mary is the Director of Conversations for Life. Can you just explain what that is and your motivation in getting it started?
Actually, it's not very dissimilar as the motivation. Conversations for Life, I said in the workshop yesterday, my mother's death was the birth of Conversations for Life. And it was my perspective as a healthcare educator, as a community facilitator, as an executive director of a number of health-related charities in the States before moving to England, that I realized that I knew a hell of a lot about advanced care planning, but it didn't have a whole lot to do with what we needed to know to actually talk about, connect up the care, and achieve my mother's death at home, which is what she wanted as well. And they were the conversations that I needed to know as the healthy baby boomer daughter. I knew how to do the forms. I sat on compassionate care committees, but I'd never done any of it myself. I realized how distanced we can be from that. And my own mother actually said to me, I don't want to struggle anymore. And that was the beginning of her conversation. We had the forms. It was on a magnet on the refrigerator in case the emergency services came in. But that wasn't what helped us get the care that she wanted. And all the conversations and the connected up of services, volunteers, hospice at home, palliative care, all of it, which actually happened quite suddenly for my mother, which was a blessing for our family. But so Conversations for Life was what I did as a result of that experience. So I had a vision for a public health awareness initiative aimed at baby boomers to engage people in the need to have these conversations while we're well with our families and to start to engage the strengths and assets of communities to volunteer. So that's a bit of the background.
Yes, sorry, I didn't mean to interrupt. I guess I thought I attended Mary's session yesterday and heard about the Cumbria Conversation for Life public health program, and I thought partly going towards answering Peter's question, it would be interesting first to hear about that program and then your thoughts on what would be the beginning steps for a man like Peter who's so highly motivated. But let's begin with the Cumbria Conversation for Life and just the key elements of what you did and achieved there.
The key elements in that program, it was literally the first public health campaign around end-of-life conversations and care in England through the risk-taking of the commissioners at the time in public health, not end-of-life, which was key. It was health promotion. It was public health aligned with health, and we had a multiple service represented steering group for the project. We developed a film of local people's stories to raise awareness so that, as important as it is to go out and advocate, the film could be used. It was linked to a website of the local services and information that people need to talk about earlier, not just advanced care planning, but people are curious about funerals, bereavement support, all of the different things that a family as a baseline might need to talk about early. And then we delivered public workshops in the different localities of the region that helped people not only learn about why they needed to have the conversations, but also start to practice how they'd get over that first, we don't want to talk about it. And so it received a national endorsement from the End-of-Life Care Program in England. It was a privilege to be a part of launching, and for the people who participated, I guess a bit to your question, I don't think there's anybody out there that doesn't have a gift to share in this arena. I don't think there are very few people that don't have their own personal experience. And everyone that we spoke to be part of the film, to be part of who came to the workshops, everybody has something to contribute to this. Most people think they don't. I don't have anything special to say. I don't have anything special to offer. I'm not trained. I'm not this. I'm not that. But everybody's got something. And so the act of sharing your story, the act of raising that awareness, the act of coming to a workshop not to learn how to fill out a form, but to connect up with other people in your community and say what's possible. So there are other things, but
that power of personal stories, that's one of your key messages, isn't it?
Absolutely. Stories connect. Stories since the beginning of time have changed culture. Period. And we have got to tell our stories more. Staff have to tell their stories, your personal stories, we have to tell the truth. We have to tell it from the heart. And that changes things more than anything. And a lot of the people who talked about wanting to be cared for at home, or even in our short film, the woman who actually who was willing to be filmed to care for her mother at home, she didn't even know it was an option to be cared for at home. We talk about all these things about just telling people it's possible, just telling people we did it. And then she said the only question she really had was, when was her mother going to die? Like, how would she know that was going to be the moment? Somebody actually was able to give her that answer, and she was comfortable with it. So I'm not saying that can happen in every circumstance, but there are really simple solutions if we just listen to people.
We've got a 1-minute video, Mary, and I wonder if I could ask Rob to line it up. But just before he hits the play button, what are we about to see? It's that same 1-minute video you showed yesterday.
Right. This is actually it was a 1-minute clip that we were trying to use for some funding for a larger project. So this is an excerpt from the film that we did in Cumbria that was about 13 minutes long. I'm on this one. I'm not on the real one, but it was part of editing. I don't want my family disagreeing at the bedside over what I want for my care.
I don't think he would have wanted the treatment that he received. But by then it was too late.
It's easy to be swept along by the health industry.
Stan said to me, I don't want any more treatment. I just looked at the doctor. He said, yeah, but if we tried this, it could. I said, no.
That switch over from saving life to managing death is something which we haven't been very good at training doctors and nurses about.
When Emily got up, Mum had obviously been waiting for her, and she opened her eyes, and Emily went and took her hand, and then she died. And it was horrible, but it was lovely.
We don't have a crystal ball of what the end will bring, but if you make your preferences known, those around you can do their best to support them.
A round of applause. And I note the power of what you can achieve in a minute, with good communication skills. Help me, guys. You could tweet a link to that, couldn't you? You could tweet a link to that 1 minute. I'm just going to obsess about getting you into social media, okay? Because what Mary just said, makes my heart squish. People don't even know it's possible to die at home. Most people don't know anything at all, do they? So the power of this social media to get tweeted out into the universe beyond yourself is... I meet people who know about me I've never met, and it's all because they've seen some tweet that's been tweeted into the stratosphere. I just want to get a couple more things from Mary, then I'll open to some questions, and then I'll come back to my panel. But the other thing that you emphasised yesterday was the importance of working locally and collaborating. Again, do you want to share what you did in Cumbria?
I could share
or something else.
Yeah, a bit about Cumbria. The other phase of this, because no one here, I'm sure, is used to budget cuts. So as we had hoped things would roll out, they didn't necessarily happen that way. So we found a different way to facilitate communities to launch their own awareness initiatives in ways that they would like to, using more of an asset-based approach, and that's what I spoke a bit about yesterday. The working collaboratively, though, was bringing people together who don't... palliative care was represented, but they weren't the lead. And different community organizations, it could be women's groups, it could be the Scouts, it could be anyone, And they don't actually know what it is they're coming together to do, except that it has something to do with raising awareness about death, dying, and loss in their community. And in a facilitated process, they then realize the assets and strengths that they bring as individuals, as organizations, and the reach that's possible as a result. And that might be another way that we all have those strengths. But working collaboratively then, those communities lead on initiatives that kind of support the top-down, looking that there's a strategy, but also in the grassroots level of people working on things as passionately as school youth projects, or as caring for people with dementia, or just raising awareness in their community, or creating a bucket list project, but they're driving it. And then the services, the information that exists, people can tap into.
You also mentioned independent facilitators. Why do you think that's important?
Because almost everything in this arena is biased and siloed. Our lenses on who owns end-of-life care are really messed up. And from a public perspective, I think you said this yesterday, nobody cares what your role is. You just need to get the job done. You want people want the best support possible. This is my personal opinion. But I lost my train of thought, Julie. What was the question?
The question was, what use are independent facilitators, for example,
yes,
in dealing with those issues you've raised of ownership or silos?
Yeah, in a room where you have health, just one person representing all these different groups, but health, public health, social care, women's groups, cancer support service, any of these different, the faith groups, all in the same room, funeral. Somebody can co-opt that meeting really easily. Somebody can lose their voice amidst somebody that is perceived to be more informed than them. So the independent facilitation just gives a really neutral playing ground, and the facilitation is based on everyone in the room taking off their badge and starting from being a human being that has a family or their own circumstances and will one day die, and also has their own personal story to bring to the table.
Look, thank you. I might come to Sue first before I go to the audience, but would you like to give Mary, please, a round of applause? Sue, the question is, how do we reach out and engage with the community? I think you've got some thoughts about examples in Japan and the UK, and also in relation to dementia here in Australia. But just before I come to that, you're an example of someone who, through writing books and going onto the mainstream media to tell your mother's story, has been enormously effective. So in raising issues around people with dementia and about end of life. So you're an example of the power of a story, aren't you? And in a way of a celebrity, because of in the sense of the status of your family being linked to a Prime Minister.
I prefer not to think of the celebrity or Prime Minister thing. I think the root of the influence in this case was just the breadth of incredible fondness for Mum. And so when Mum came out as having dementia, it came at a critical time where Alzheimer's Australia had been working so hard that there was then a support network. And I think this is what happens when you talk about changing things and building conversations. You can look at various social change movements and see that it takes time and building conversations and breaking down taboos and opening up comfort levels and creating new relationships and connections. And this happens over time, but then there can be some critical moments, like when Mum came out having with dementia, was the beginning of starting to erode the stigma around dementia in Australia, I think we could say. And then when she died, and Australian Story, with our cooperation, went to air within days of her death.
I'll just explain for our international visitors, this is a national story on our national broadcast, a program that does intensely personal documentaries.
And we cooperated with them and talked with them about being with Mum and her death, and we and the ABC got extraordinary response to that, which I think really just says one of the things was that people were just so pleased to know that Mum had died well and with her family with her. Like somebody they cared about had had a good death. There was other people who were just so pleased that it had been talked about. And I think, in essence, it comes down to it being talked about. And I think there's some things you can say about that, and I perhaps come instinctively to this, but there's certain fundamental things about being human which we've somehow displaced facing the fundamental essence of them. And that displacement has happened through medicalisation. And I would say the two things that we all have in common, if nothing else, are being born and dying. Neither of those is a medical event, and yet they tend now to occur in the medical domain and are thought of as being properly managed in the medical domain. Well, I obviously didn't think so because I had a home birth with both my children, with a skilled midwife there. I'm not talking about rejecting the contribution of good medicine in any situation if and when it's appropriate and needed. But there's something about taking back your power and empowerment with birth, which is another whole conversation. But I think it's a not dissimilar conversation to the conversation about death. We're talking about the bookends of life, if you like. And dying well, it's not something I don't bring the expertise to it that a lot of you do. I bring my experience with my mum and the level of exhilaration, in a sense, that left me with, along with the grief and the other things. The sense of no regret of having done our best for her, of nothing left niggling us or not feeling undermined or unsettled about the experience. The sense that it had been a contribution to my kids. Now, I think talking about all of that and finding opportunities, like, you just have to be willing to be a bit outrageous sometimes. Like, I was at a dinner party with a mob of my daughter's friends, all sort of late 20s, and I was talking about dementia, and this was like, not what that age group talk about, but you get going, and sooner or later they've all got stories. And one of them said, "Oh, if I get old, I might." And I just looked at her and laughed and said, "Well, honey, you're either going to get old or die young." It's like, I think we need to lighten up. We need to bring in the willingness to be a little bit provocative, a little bit outrageous, always with compassion, but also to have people sense the value that's there if they're willing to step over that taboo. You can see various communities where it's happened. I remember when the AIDS scare hit, how utterly transformed the gay male community was by its members being ill and dying, and the support networks that were formed. My son's godfather personally nursed several of his friends through their death, and they had various networks and so on where they educated themselves to support each other and bring meaning, and in so doing they broke down taboos and had the Roman Catholic nuns looking for dope for pain relief for people who were terminal, and families coming in and meeting boyfriends and they'd never been willing to accept them, but now death was there. Sorry, I'm rambling, but I think I'm trying to give that sense that when you open up something that has been taboo, you're not just shining a light on something terrible, you're actually creating opportunity for connectedness and community and communication and meaning and satisfaction and contribution and all those things that are the core things that people want to be the substance of their experience in life.
Can I just pause you there for a second, because I'd just like to have a round of applause for rule-breaking Catholic nuns. Because I think we've all come across a few of them and they're wild and the Pope hasn't got a chance of controlling them, and there's comfort in that. No matter how good the Pope is. But look, just before I open up to the audience, Sue, can I just ask you this, coming back to Peter's question, what is our advice for him on how to be an advocate for home-based palliative care? You're obviously an ambassador for Alzheimer's Australia. You've been involved in a lot of other social change movements. A few thoughts for Peter as he takes his first steps trying to become an advocate for home-based palliative care.
Link up with everybody who's working in the space you work in. Work collaboratively. One of the things I've been called is the accidental advocate. I never actually intended to become who I've become in that sense, but I wrote the books on mum, and you go around and you talk at some bookshops and people are interested, and then somebody else asks you to speak, and then you realise you're doing it enough that you better start charging for it, and you're amazed people are willing to pay because you seem to deliver some value. It's extraordinary. But the thing is, you link up, find the organisations that have the same sorts of commitments, build collaboration. I love what you were talking about, and look for opportunities to talk. Local media, the suburban newspapers that we all tend to throw in the recycling before we look at, they're actually not a bad place to start because they're always desperate for stories. Yeah, they're desperate for copy. So...
Can I just jump in there? So, they're great ideas, I think. The issue of organisations that are active, there aren't any. There is no body of people who... these people have their living to make as professionals. I'm talking about users of their services. I'm talking about people who live out there in the community and who next week will get the news that their life will be turned upside down. They'll be fearful. They would never have considered the possibility of death occurring.
I think
it lacks organisation. There are no advocates that I can see because there's no one employed. There's no one whose job it is to do this.
Could I come to Robert for a second? He's just looking interested. Thank you. I mean,
the bottom line is the first thing that you all can do is have a daughter, because when you get old and you get sick, with rare exceptions, you're going to be taken care of by a daughter. You're not going to be taken care of by a son. That's the demographics. So if you all have only sons, you should start paying your nursing home bills now. Second, this really doesn't apply to you guys because you're all middle class. The real problem is the people who are trying to do this have a job that if they miss their job, they don't get paid, and they have a husband and 2 little kids at home, and they're trying to do it at the very end. And so in the end, whether you build community and get people to talk to each other, if you don't get your government to support this and support the informal caregivers who are basically spending an enormous amount of time and money in getting not paid and losing their jobs and going bankrupt. At least in America, the leading cause of bankruptcy is serious health problems in family members. If your government isn't going to do it and isn't going to support it, I'm sorry, people are going to use places that basically are free support. Because what else are they going to do?
Mary's head is going up and down involuntarily. Why are you nodding so much? Tell me. Seriously, what's going on in your head?
That's a scary question. Yes, and yes. I think the space between what the 2 of you were talking about, or the 3 of you were talking about, is the space between good-intentioned people and, I was going to swear, reality. And I think we are living at a time that we have to build new bridges, and I don't know what they are. I think we're here to build them.
And you're speaking from the British context where...
No, I'm kind of a confused context.
Okay.
But yeah.
I suppose I only say that in that there has been a very substantial cut to the community sector under the current government. Isn't that
significant?
The case?
Yes. And even before that, when I was living in America,
just give her a chance.
The state, the government, the fund, it doesn't exist anywhere. And the need exists everywhere. So there is, yes, it has to come from government, and yes, if we wait for government, it ain't going to happen. There has to be some sort of bridge between the two.
So
we'll come to Robert and then to Sue.
I have to say we have to push government. I mean, the problem is that I'm a doctor. We spend too much on medicine and not enough on the social determinants of health. And the biggest things, until, if you look at before 1950, nothing that happened that was about living longer had anything to do with doctors. Doctors only did bad shit. It was all clean water and education and increased social economic status. And if you want to look at what needs to happen now, if you really want people to do a better job at the end of life taking care of patients, it isn't that doctors and nurses can't do a good job. It's that if you don't have a social support network for them to do a good job. And the real question, the hard part is that when the people in the middle take care of their parents and then their parents die, then you want to go back to your normal life. So there is no built-in advocacy group as there is for the women's movement or the civil rights movement, because we're all in that group for 5 or 10 years, and then when the person dies, we move on in our lives.
And can I just ask you one quick question? That reference to only middle-class people engage in home-based palliative care, was that anecdotal, or have you got some evidence for that?
No,
that was a serious question. I'm not saying you're wrong, but are we going from evidence or anecdote?
If you look at in America, because what the hell do I know about Australia, except for it was good to hear someone else who talked funny. If you look at America, nurses, physicians, chaplains are basically, if you look at their incomes, middle class. Social workers are sort of lower middle class.
No, my specific question was, were you quoting on research about who does home-based palliative care? I'll just pause you for a moment.
No, I'm not.
You're not. Thank you for admitting that or acknowledging that. The reason I say that is I heard Peter, in front of several ministers of the Crown in Parliament House, ask that exact question, because my understanding, Sue, is you've done some decent searching and you can't find good quality research on how much palliative care support is happening at home, where it's happening. Just tell us what you've discovered, because this guy is an economist who's gone looking.
Yes, well, I think it's bizarre. I've never worked on a social issue before. I've never worked on this social issue, only from what I've said. But I have looked at it recently, and it is bizarre that we don't know with reliable statistics the rate of deaths that occur at home in palliative care system in any state, and certainly not as an integrated statistical collection which is regular, updated, agreed on in terms of statistical definitions and methodologies. It really is a nightmare to try and work it out, and lots of people have done a great job, but there's an awful lot of assumptions, and there is no data set that's continually updated. Now, I say that's bizarre because underpinning explicitly or implicitly all of the literature and all of the information that comes from your sector, there is this assumption that that's what we work for, at least to the maximum extent possible. That is, a death at home or some period of palliative care at home. In that event, how could it ever be that targets aren't set and monitoring is in place?
Welcome to government policy.
I'll just hold you there. Can you see the power of this man's questions? Because if you're going to a Minister of the Crown or you're going to Treasury to get serious funding so that if I'm sick I can get you into my house, you need proper research. And we haven't talked a lot about research other than the form inside our bag. But without this kind of data, advocacy has got both arms tied behind its back. I don't know if you want to comment, Odette, because I know you're a passionate advocate, but is this a glaring need for research to have proper data on what's actually happening?
I just really say that we have some data in Victoria, but it's mainly contact data rather than individuals. But I think what Peter's pointing out is we don't have good national consistent data or good access to that data. So even preparing our call to action and getting evidence to support our call to action was an incredible amount of hard work to try and bring together different data sources and interpret them to get outcomes. So that's a real problematic situation that we do need to do better at.
Thank you very much. Look, I've got I'll just be 1 second, guys. I've got 15 minutes to go, and I want to hear recommendations for action that can make a difference. And I'd like to go to the audience, if I may, because I haven't gone to them enough. But I will give you a chance for a final comment. But it's action to make a difference now, no longer problem. Thank you. I'll come to this lady and then to you, sir.
Thank you. Donna Watmar, Alzheimer's Australia Vic. Peter, thank you so much for that passionate statement about the need for credible data. And I have here End-of-Life Care for People with Dementia, Survey Report February 2014. I've got some hard copies at my booth, or it's available on our website. Here's some data. Do people with dementia have access to palliative care services? 58% stated that the person with dementia did not have access to palliative care specialists. 68% indicated that the person with dementia did not have access to hospice care, and 49% indicated that there was no support available in the community at end of life. 26% reported that they were dissatisfied with the care the person with dementia received at their end of life. The article also quotes the gap between what people perceive, that is, those of us who are health professionals estimating what we provide, and the gap, and you could drive a bus through it. So here we say that 75% of care professionals indicate that people with dementia have access to palliative care services, but our consumers tell us saying that 58% lack access. I won't read any more data, but look, that is a consumer survey on our website, and our organisation, the key body for dementia palliative approach, advocating at the highest governmental level and at the parliamentary level in Victoria.
Thank you very much for those comments. Thank you. Just come forward. I'll just bring this gentleman forward. It's always hard if people are up the back of the room for them to maintain focus. I'll hold it.
Thanks. Mike Kennedy from Palliative Care Victoria. I want to respond to Peter as well. And I think what we need to be doing is having a discussion between, if we're going to talk about data, between government and community. I got involved in this sector, although I didn't know it was this sector, in the early 1980s when we were setting up home-based care teams for people with HIV to die at home. We didn't call it palliative care. If you said, well, we're doing palliative care work, we'd have said no. Come into the sector last year, start talking to called communities and hear Italian and Vietnamese women telling me they're not carers. I'm not a carer, I'm a wife. And so it depends on how you ask the question. If you were asking those people, were they working, providing palliative care, they'd say no, they'd say I'm looking after my husband. And so I think there needs to be a broader discussion about what the categories are before we then start counting people and dropping them into those boxes.
Thank you. Do you want to stand up just so people can stare at you?
I'm Margaret O'Connor from Monash University and Melbourne City Mission. I wanted to respond to Peter too. In Australia, the Australian Institute of Health and Welfare release a report about palliative care every year. It's that thick. Any insomniacs, I'm sure, would have read it. It provides incredible detailed data about the palliative care deaths in hospitals, and the death at home rate is calculated by taking away that from the total deaths. I would suggest that there is work to be done with working with the AIHW in expanding their data set, because that work already exists.
So what they'd have to do is to examine more deeply the deaths at home in order to find out the sort of things that he's interested in.
Well, we have to attract government resources into an area, because they're only interested in hospital because of the money that's saved. So we need to expand that data set by making that argument about home care.
And Margaret, obviously Peter's an individual. Is one of the sort of collaborations he should look for with someone like yourself or a major research unit to, do you know what I'm trying to say? What would you recommend him as a step? Because you know it's often people like this that make things happen.
I think the peak bodies are the way to go.
Which peak bodies?
Palliative Care Australia, Palliative Care Victoria, and obviously the research arms, but it's really government and the sector.
Thank you. I'm going to keep letting the audience speak. I know that two of our people have to leave at exactly past, so I will finish on time, but let's just get a little bit more from the audience. Do you want to stand up?
Well, I've got Julie to run that far. I'm going to get her very fit. My comment is that the concentration on dying at home is not always achievable. Families may not want it, carers may not want it, the person may not want it. What we really need to be looking at is what is our success rate at helping people stay at home or their place of residence for as long as possible. And unfortunately, our measurement at the moment is all about where did you die? Well, in actual fact, if I'm still at home the day before I die, but my wife doesn't want me there to die, spending my last day in hospital may not be such a bad outcome, and certainly is a very successful outcome for community-based palliative care.
Hi. Peter, I would agree with Marg. I think we're not just paid workers in the sector. I think most of us, it's a vocation, and we do a lot of work beyond the sector. I think that I could find, maybe half the audience who are as passionate as you about dying at home or staying at home for as long as possible, and that through our peak bodies we may well be able to connect you with people who've been through your experience and form some advocacy through that. You're not alone, but you're a great leader, so thank you.
I'm going to take two more from the audience and then get a final comment from my people. Where was the hand here? I'm sorry. Oh, Jane, do you want to...
Yeah, I just wanted to say that I think we're really behind the eight ball. We've got a government that thinks it's okay not to pay young people when they're unemployed for 6 months and make them apply for 40 jobs a month. I don't understand how that can possibly be. I think I'm going to break my neck, Julie.
Why don't you stand up?
Oh, yeah, okay. Then you can't reach me. So I don't know that the peak bodies are going to do it. I think the stories of people like Mary and Peter, I think they're much more powerful. If this government doesn't even listen to what must be huge opposition to these unemployment changes, I can only think that the stories of people is going to be much more powerful. So I haven't got any answers, so I just feel profoundly pessimistic.
Well, there's our challenge is always the challenge of hope. Can I just quickly say, I've just realised I've forgotten to do something which I must do in this time, but Palliative Care Australia, the launch that they did, it was all stories. I was given the task of interviewing a series of people. They had no speeches whatsoever. They only had personal stories to a room of politicians. I got so caught up, I haven't spoken to Jenna De Bono. Rush towards me quickly, Jenna. And could Andrea Grindrod rush towards me as well? I want you to meet these two people, and yet we're still going to land the plane on time and hear from the panel. Let me start first of all with you, Jenna. Calvary Healthcare, Bethlehem. You're involved with young people in a schools project. What are you up to?
Cool. So, I'm involved in a schools project, and we're getting young people. We've got a group of 35 Year 10 girls. They're about 15 years old. They've been coming into the hospital setting, and we've also been doing workshops with them at their school about them opening up the conversation about death and dying. So, at the hospital, they've had workshops with the clinical staff, with allied health. They've been meeting the patients. And all the workshops were sort of run by with things specific to the field. So with the speech pathologist, they were asked to try some of the food, for example, that someone who is in palliative care might have. In music therapy, we wrote a song about their experiences. In physiotherapy, they got to try out some of the equipment that they might use, some of the exercises they might have to, someone who is palliative might have to do.
And you're making a DVD?
Yeah, so there's kind of two parts to the project. So now the girls are away and they are making some artwork, and it's going to be put into an exhibition in a public gallery somewhere. We haven't quite decided where the public gallery is going to be. So they're going to be expressing their views on death and dying through artwork, and also what it's like to be in a palliative care setting. And then we're going to document all of this in a DVD and use it as a health promotion tool to go into the community and start the conversation of death and dying to community groups and other schools.
Just before she goes, I love the fact she's talking about the young, right? That's not herself. I've just done something instinctive that I always do. I understand Jane's despair, and I also understand she's someone who makes an enormous systemic national contribution. But whenever that spooky little baby boomer bit of despair comes in, I grab someone young who's entered the field and who's just at the beginning of their journey. So thank you so much for that. Let me grab you as well. Let me introduce Andrea Grindrod, a Health Promotion Officer at La Trobe Uni Palliative Care Unit. And you're working with a group we haven't mentioned yet, people with intellectual disabilities. So what's the core of what you're doing?
Well, La Trobe University has partnered with the North West Metropolitan Region Palliative Care Consortium to do a funded research project to look at where these people their place of choice for dying. So the gaps that we've talked about for the general population is 3 times more significant for this population because they're living in group homes, they're disenfranchised from their own death, and they're purposely excluded from the decision-making process around their own death. And because of their intellectual capacity, it's assumed that they shouldn't have that kind of conversation. So the barriers for them to have a death in their place of choice, and we're assuming that it's within the group home setting, which is their home when they live with their co-residents, is really, really significant.
And this group have a high rate of dementia and often also die younger, don't they?
Yeah, that's right. So they tend to die younger than the general population, but they're also living longer, as is the general population as well. And so they're ageing with significant complex issues, and the community setting in which they're living isn't set up for ageing and dying, it's set up for self-determination and support, so they're not being able to get that sort of support that they're needed. The work that we're trying to do is a health promotion project. We're looking at the disability sector from an assets point of view to think about how we can mobilise that sector to take the leadership in caring for their population, their ageing and dying population, so that they can get the very best care that they need, because really they're the ones who are going to be providing the disability support workers 80 to 90% of that care. And with someone with an intellectual disability, it's even more important that they're in a familiar environment, because they become very distressed where it's unfamiliar environment and with people that they don't know. The way we're going to try and mobilise and to empower this particular sector, it's quite disadvantaged, and our unit is interested in the disadvantaged populations and how they die, like homeless people and so forth, and people with disabilities are one of those populations who are one of our vulnerable populations and specifically disadvantaged. We're going to conduct a research project starting the next couple of months. We're looking at a survey that looks at attitudes and current practice within the service system, and we're looking at the connections between how attitudes impact on current practice. Hopefully by the end of the research project we'll be able to get a sense of how people are feeling around people dying in the group homes, whether they're having the conversations at all, and the literature shows that they don't even talk to the person who's dying. The person doesn't know that they're dying. The housemates don't know that that person's dying as well. And we're looking at the practice for that, best practice.
Thank you so much. Give a round of applause. I have just a couple of moments left, so I won't come to you first because both these men are going to leave the stage in 2 minutes. I would love to hear a final comment from each of you. I wasn't meaning to overly focus on dying at home. I was more trying to focus on Peter's desire to be an effective advocate with the community, which is the focus of this session. So if your last comment could be one thought on effective advocacy out in the broader community, that would be useful. Do you want to go first, sir?
Yes. Look, I would invite you to email me, and I'd be very, very happy to hear from you. I'd like to enter a dialogue. My email address is on the big list that you've all got. Have you all got a list of participants? And I'm also on Twitter, and my thingy is there, whatever it's called. It's called a handle. That's it. I knew that. Yeah. So thanks very much for listening to me, and I hope to keep up contact.
Thank you very much, Peter.
I guess the only thing I would say is, there are lots of places that need a difference, and just choose one and do work on one. I mean, there are things in government that need changes. There are sort of personal things that make changes, and you can be pessimistic and sort of overwhelmed. And my recommendation would be to work on one, sort of have fun doing the work on one, and just keep at it. And it's the last thing I'm saying before I go on vacation, so goodbye.
Could I just quickly say thank you very much to both these gentlemen, because I think you both need to go and get your taxis, so thank you. Sue.
I think there's just one important piece of fairly useful information missing here. Governments come and governments go, and aren't we all just waiting for one to go? But the previous government took palliative care very seriously. A couple of different ministers, including Mark Butler, found that it was one of the things that came out of aged care consultations around the country as being of critical importance. So they then set up a national consultative process about palliative care, which had meetings in all the main capital cities and some regional centres. I attended a couple of those. And there was people from all over the place speaking up about what they wanted to see in PAL care. And a national palliative care strategy was written and launched, and as I understand it, a not insignificant amount of money was allocated, and the importance of it within the Department of Health, and I can't tell you how important it is where you sit within the Department of Health, definitely grew very much. Now, the people in the PAL care organisations will know more about this than me, but what I'm trying to say in the face of the pessimism is I think we're talking about an issue that is no longer dead, probably under this government will suffer a lessening of resources. But anybody who is interested in advocacy, I would encourage them to find out what sorts of policies and pockets were created that might give them somewhere to hang some volunteering or some research or something on, because it's not dead at that level. There is stuff going on. And I think it's an issue whose time hasn't fully come, but it's not an issue that hasn't started, if you know what I mean. And I think there's room for optimism because of the room full of people like this and people like Peter. It's not going to roll over and die. We will keep building and advocating, and resources will get more allocated, and the conversation will become more widespread.
Thank you very much, Sue. Thank you.
Start at home. Sort it out with your own family. We talk about big community engagement stuff, but honestly, if everyone in this room, if everyone in healthcare just did it with our own families and figured out what networks we would need, continuing on with the network research that's going on in this country, which is phenomenal. In the NHS in the UK, 1 in 4 people work for the NHS. You could forget all the national campaigns if every NHS staff person just did their own future care planning and figured out what resources and what networks they would need, we'd change things. And I think it's going to come down to that simple a level in addition to all of the things that have been said. You find out what's not there, you go figure it out. We've got to do it in advance, and we've got to start at home.
Wasn't that an interesting two last responses, you know, so systemic and so personal? Would you give them both, please, a warm round of applause?